So radiotherapy is, I mean, it's an absolute medical marvel.
Oh, without a doubt, it's totally revolutionized oncology.
Yeah, it's a tool that can completely eradicate these highly aggressive pelvic cancers. It's curing people today who, decades ago simply wouldn't have survived.
Exactly.
But, and this is what we're looking at today, decades after a patient is declared cured and, the oncology clinic has rung the victory bell, a completely bizarre, silent mechanism can trigger the internal walls of their pelvic organs to just, well, dissolve.
Yeah, it's wild. It's a devastating structural failure. And welcome, everyone. I'm thrilled to be here for this deep dive into what is really the hidden legacy of a life-saving treatment.
And I'm your host, ready to jump right in.
Mhm.
Because it's a completely different kind of battle, right? And one that occurs entirely in the shadows.
Right, because the acute phase of cancer treatment gets all the attention, understandably, but the late-stage physiological fallout is incredibly complex.
So today's deep dive focuses on pelvic radiation disease, or PRD. Specifically, we're looking at one of its most severe complications, which is radiation-induced fistulas.
Yeah, the fistulas are just brutal.
And our core mission today is to answer this really specific, fascinating question from our source material. Can a pelvic radiation-induced fistula cause complex fluid shifts in the body?
Which is such an interesting way to look at it.
Right. We're going to explore the precise mechanisms of how radiation reshapes human tissue, the profound, plumbing failures these fistulas create, and the highly specialized surgical techniques used to repair what honestly looks like an irreparable biological wasteland.
And we have a phenomenal stack of sources guiding this discussion today.
We really do.
We're synthesizing clinical guidelines on managing long-term radiation toxicity, some incredibly detailed surgical technique papers from the journal Gynecology and Pelvic Medicine, and comprehensive oncology symptom management resources.
It's a deep bench of data.
Exactly. It paints a really vivid picture for you of both the pathophysiology and the cutting-edge interventions.
Okay, let's unpack this. Because to grasp how fluid is shifting in such chaotic ways across different, anatomical compartments, we first have to understand the architectural breakdown of the tissue itself.
Right, the root cause.
Yeah. When a lot of people hear radiation damage, they instinctively think of, a thermal burn, like a severe, sudden injury.
Which, to be fair, is an accurate description for the acute phase. During or immediately following radiotherapy, you do see acute mucosal inflammation, ulceration, erythema.
So it's a highly volatile, inflammatory environment at first.
Exactly. But the critical error is assuming the damage stops there.
Ah, right.
Radiation toxicity is a progressive, multi-stage disease. The real structural danger lies in the chronic phase. And that operates on a timeline of months, years, or even decades post-treatment.
Decades. So, okay, let's unpack this with an analogy. The sources describe this chronic phase as a creeping breakdown of the tissue's infrastructure. So it's not like a pipe suddenly bursting from high pressure.
No, not at all.
It's more like, the pipes quietly rusting from the inside out over years until the structural integrity of the wall just crumbles away.
That is the exact mechanical reality. And what's fascinating here is the primary driver of this rusting effect. It's a condition called endarteritis obliterans.
Endarteritis obliterans. Okay, what is that actually doing to the tissue?
Well, ionizing radiation causes profound, often delayed DNA double-strand breaks, specifically in the endothelial cells that line the microvasculature.
So the tiny blood vessels.
Right. And over time, those damaged endothelial cells undergo apoptosis or they just become senescent. So the tiny blood vessels literally scar over, they thicken, and they close up entirely.
Wow.
Yeah, you basically just lose the capillary beds.
Which initiates a catastrophic ischemic cascade, I imagine.
Precisely. The tissue is subjected to chronic ischemia. Without adequate microcirculation, the local environment becomes severely hypoxic. It's starving for oxygen.
And how does the body react to that starvation?
Well, in response to the hypoxia, your fibroblasts go into overdrive. But they lay down dense, disorganized collagen. So this is the progressive tissue fibrosis. You're replacing elastic, functional, highly vascularized tissue with this rigid, starved scar tissue.
So the tissue essentially becomes a rigid wall that inevitably gives way.
Exactly.
And because the pelvic anatomy is so tightly packed, you end up with this compromised ischemic wall sitting directly between two distinct organs, like, say, the bladder and the vagina, or the rectum and the vagina.
Right, they are right up against each other.
So when that fibrotic wall eventually breaks down and dissolves, you get a fistula. a literal hole.
Yeah, and what's fascinating here is that this ischemic environment is highly unstable by definition. The tissue just cannot maintain its own basal metabolic needs.
Because it has no blood.
Right. So once that anatomical barrier gives way and the fistula forms, you have created a completely abnormal tunnel between two distinct epithelial environments that were just never meant to communicate.
Which catapults us directly into the core question of today's deep dive, which is the fluid shifts.
Right, the plumbing crisis.
Yeah. If the bladder is essentially breached by a vesicovaginal fistula, or VVF, I imagine the physics of the organ completely fail. I mean, the bladder is supposed to be this highly compliant, pressurized holding tank.
Exactly.
But with a VVF, it must just become a passive funnel, right?
That is exactly what happens to the urodynamics. Normal fluid management relies on the detrusor muscle expanding to accommodate the volume of fluid, while your sphincter maintains resistance to keep it in.
Makes sense.
But a fistula destroys that pressure gradient entirely. You have a continuous, involuntary fluid shift dictated entirely by gravity and the path of least resistance.
So the urine just falls out.
Yeah. Urine continuously shunts out of the bladder, goes through the fistula, and pools directly into the vaginal vault.
Meaning the bladder's functional capacity basically drops to near zero.
Right. It never reaches sufficient volume to trigger a normal voiding reflex. So patients might, try to void voluntarily, but they're only expelling residual tiny amounts of urine through the actual urethra.
Oh, wow.
The vast majority of their renal output is completely bypassing the normal anatomical pathway. It's this relentless, uncontrollable fluid shift. It just abolishes normal urinary dynamics.
And the sources detail scenarios where this fluid shift is far more dangerous than just localized anatomical leakage. Like, we aren't just talking about fluid moving downward, right?
Oh, no, not at all.
Sometimes the radiation damage creates tracts where urine shifts upward or outward into entirely different compartments of the body.
It can become incredibly dangerous if the fibrotic breakdown creates a tract into the peritoneal cavity, for example.
Wait, into the abdomen?
Yes. You suddenly have a massive shift of urine pooling around the intestines and major abdominal organs, and urine is highly irritating to the peritoneal lining.
I can't even imagine.
This rapid fluid shift disrupts the body's entire osmotic equilibrium in the abdomen. It leads to localized chemical peritonitis, severe abdominal distension, ileus, nausea, and just intense pain.
So the body is effectively third spacing its own metabolic waste into its most delicate internal compartment.
Exactly. It's a staggering systemic failure.
That is terrifying. And trying to pinpoint exactly where this fluid is coming from, especially in a pelvis that we just established, is a rigid fibrotic web of radiation scar tissue. It sounds like a diagnostic nightmare.
You would think so, yeah.
But the methodology doctors use to map this specific fluid shift is brilliant. And honestly, it's shockingly low-tech compared to the damage itself.
Oh, you're talking about the dye test.
Yes.
It remains a gold standard because it completely bypasses the visual noise of all that scar tissue on a scan.
I found this absolutely fascinating in the clinical guidelines. I mean, you have high-resolution MRI and CT scans available, but to figure out the exact fluid dynamics, doctors literally rely on basic physical properties.
It's so simple but so effective.
They place a tampon in the vaginal vault. Then, they retrogradely fill the bladder with a blue fluid via catheter, and simultaneously, they give the patient an oral medication that turns their renal output, their actual urine, bright orange.
Right, so you have a localized pool of blue fluid in the bladder.
Yeah, and a continuous stream of orange fluid coming down from the upper urinary tract, from the kidneys.
And then the physical evidence on the tampon tells you exactly what the fluid is doing.
Exactly. So if the tampon turns blue, you have definitive proof of a vesicovaginal fistula. The fluid is shifting directly from the bladder into the vagina.
Right.
But if the tampon turns orange and there is zero blue fluid, it proves the fluid shift is happening higher up. The orange fluid is bypassing the bladder entirely, leaking directly from the upper urinary tract into the vaginal vault.
It's an elegant physics-based way to map a highly complex internal fluid shift without needing a single imaging scan.
It perfectly leverages the distinct anatomical pathways. But, the existence of this permanent structural leak often leads people to ask a very logical biological question.
Oh, I know where you're going with this.
Right. This is where I immediately get tripped up.
Yeah.
If the body is continuously leaking fluid into the wrong cavities, why can't the immune system just patch the hole? I mean, if I suffer a deep cut on my arm, my body initiates a coagulation cascade, it forms a fibrin matrix, and it pulls the edges together.
Right. Natural healing.
Yeah. Why is a radiation-induced fistula completely incapable of natural wound healing?
Well, it comes right back to the endarteritis obliterans we discussed earlier. Think about it. In a normal laceration, the local vasculature dilates. The blood vessels act as a highway, and they rush neutrophils, macrophages, and new fibroblasts to the injury site.
To build new tissue?
Exactly, to initiate angiogenesis. But in an irradiated ischemic field, that highway is completely obliterated.
So there is literally zero delivery mechanism for the immune response.
None. The tissue surrounding the fistula is biologically inert. It is a hypoxic dead zone. The immune system might, chemically recognize the breach, but it physically cannot deliver the cellular building blocks.
Or the oxygen.
Right, or the oxygen required to synthesize new collagen. Natural biological healing requires a vascular supply, and radiation permanently destroys it.
Wow. So because that normal biological healing is impossible, the patient is left with this continuous unyielding fluid shift. And we really need to recognize that this isn't just an internal mapping issue or some isolated anatomical anomaly.
Not at all.
Because of the nature of the fluids involved, this continuous shunting creates a devastating ripple effect across the patient's entire physiological and psychological state.
The collateral local tissue damage is severe. You have to remember you are taking fluid urine, or in the case of a rectovaginal fistula, actual stool that is heavily laden with metabolic byproducts, urea, and varying pH levels.
And bathing the vaginal mucosa.
And 2047.
Gosh.
The vaginal epithelium is completely unequipped for that kind of chemical exposure. The continuous fluid shift rapidly alters the local microbiome and the pH.
Which causes what exactly?
It leads to severe vulvar eczema, painful tissue ulceration, and a chronic, highly inflammatory environment. The fluid itself basically becomes the agent of further tissue destruction.
And looking at the broader scope of pelvic radiation disease, fistulas are just one manifestation of how radiation deranges fluid dynamics. I mean, the radiation beam doesn't discriminate.
No, it hits everything in its path.
It hits the entire pelvic basin, which means other critical fluid management networks are simultaneously compromised.
Absolutely. The lymphatic system is a prime example of this. Pelvic lymph nodes and lymphatic channels are highly sensitive to ionizing radiation.
No, they get scarred too.
Yeah. When the endothelial cells of the lymphatic network are scarred and fibrotic, you lose the ability to drain interstitial fluid from the lower extremities.
So the fluid hits a roadblock.
A fibrotic roadblock right in the pelvis. It causes retrograde hydrostatic pressure. So you get this massive fluid shift into the tissue spaces of the legs and genital area, which results in lymphedema, chronic, painful, and debilitating swelling.
And the gastrointestinal fluid shifts are equally profound. The guidelines highlight bile acid malabsorption, which triggers this fascinating, albeit brutal, mechanism of fluid displacement in the gut.
It's a perfect example of a cascading fluid failure.
Mm-hmm.
Normally, you have specialized transport proteins in the terminal ileum that actively reabsorb bile acids.
Right.
But radiation enteritis destroys those transport mechanisms. So the bile acids bypass the ileum and spill directly into the colon.
And the colon doesn't like that.
Not one bit. The colonic mucosa reacts aggressively to bile acids. It fundamentally alters the osmotic gradient. Instead of absorbing water, the colon rapidly pulls massive amounts of intravascular and interstitial fluid into the bowel lumen.
Basically, a massive osmotic fluid shift resulting in severe chronic diarrhea.
Exactly. It's a rapid depletion of the body's fluid volume, leading to incredibly high risks of dehydration, electrolyte derangement, and systemic malnutrition.
So what does this all mean for the patient? I mean, it means wave after wave of physical breakdown. But the clinical papers do a surprisingly good job of capturing the human element of all this physiological chaos.
They really do. The psychosocial morbidity is immense.
We are talking about patients who survived grueling cancer regimens, but are now tethered to incontinence products 24 hours a day. They are managing severe skin breakdown and the constant psychological burden of distinct body odors.
The case studies document profound social isolation. Patients develop severe agoraphobia. Just the sheer logistics of managing these relentless fluid shifts make leaving the house, maintaining a career, or, engaging in intimate relationships feel insurmountable.
They survive the malignancy, but their dignity and quality of life have been hijacked by the structural failure of the cure. Which brings us to the intervention.
Right, how do we fix it?
Because the local tissue has completely lost its biological ability to heal because of that obliterated vascular highway we emphasized. Traditional surgical stitching is completely futile.
It is an exercise in guaranteed failure. If a surgeon attempts a primary closure, meaning they just debride the edges of a radiation fistula and pull the two sides together with sutures, it will fail.
Every time.
Pretty much. The moment you apply mechanical tension to ischemic fibrotic tissue, the sutures will simply tear through it like a wire through wet paper. You cannot suture dead tissue and expect a biological union.
So how do you physically patch a hole in a biological wasteland without just sewing dead edges together? This is where the paper from Gynecology and Pelvic Medicine introduces a truly ingenious approach.
Yes, the pedicled bulbospongiosis muscle flap.
Often combined with the colpoclysis.
It represents a total paradigm shift in how we approach ischemic tissue repair. Instead of trying to force dead tissue to heal, the surgeon brings the healing elements to the dead tissue.
Wait, okay. If you harvest the bulbospongiosis muscle from the perineum, so the external area just outside the vagina, and graft it internally, doesn't that inherently compromise the patient's external anatomy? Aren't we just trading a severe internal structural failure for a new external functional deficit?
It's a highly valid concern, honestly, but this is where the specific biomechanics of the flap come into play. The bulbospongiosis is an accessory muscle. Mobilizing it does not significantly compromise pelvic floor integrity or anal sphincter function.
Oh, really?
Yeah, the functional morbidity at the donor site is remarkably low. But the real genius is in the word pedicled.
Right, so they aren't just cutting a chunk of muscle off and dropping it into the fistula like a plug.
Exactly. If we connect this to the bigger picture, the entire goal is to overcome the endarteritis obliterans. When the surgeon dissects the muscle flap, they carefully preserve its proximal base, meaning they do not sever its original healthy vascular supply. They mobilize the muscle belly and tunnel it up into the vaginal vault, but it remains tethered to its own autonomous arterial and venous network.
So it's not acting like a passive cork in a bottle. It's more like a vascular Trojan horse.
That is a phenomenal way to visualize it. The surgeon is smuggling a living, breathing, vascularized unit directly into an ischemic dead zone.
That's incredible.
The muscle flap provides immediate mechanical occlusion, right? So it physically blocks the abnormal fluid shift from the bladder. But far more importantly, it brings a robust, healthy blood supply right to the margins of the irradiated tissue.
Supplying the oxygen, the macrophages, the fibroblasts.
Yes. It triggers angiogenesis. The flap nourishes the surrounding tissue, allowing the host tissue to finally integrate with the graft.
So it overrides the biological limitations of the radiation damage by physically importing a new vascular highway.
Exactly. And often they combine this with colpoclysis, which is partially or fully obliterating the vaginal canal, which removes all mechanical tension from the repair, creating an incredibly stable environment for the graft to take hold.
The clinical efficacy of this approach is incredible. Let's look closely at the specific case study outlined in the literature, because it vividly demonstrates this transition from physiological chaos back to baseline.
It's a great case study.
The patient was a 56-year-old woman treated for stage IIB cervical squamous cell carcinoma. She underwent full-dose external beam radiation and brachytherapy. She achieved complete oncologic remission, but 2 years later, the chronic ischemic phase triggered a massive vesicovaginal fistula.
And it's crucial to note for you all listening that conservative management completely failed her. They attempted chronic urinary catheterization, hoping that bypassing the fistula would allow it to close.
But the tissue was dead.
Right. As we know, the tissue was biologically inert. And the fibrotic bladder wall was just too rigid and spasmodic to even tolerate the catheter.
So she lived with continuous, uncontrollable fluid shifts and absolute social isolation. But then she underwent this pedicled flap reconstruction. And the surgical data alone is a testament to the precision of the technique. The entire procedure was completed in exactly 96 minutes. And the estimated blood loss was only 69 milliliters.
Which is remarkably low for a major pelvic reconstruction.
It really is. I mean, 69 milliliters is roughly a quarter of a cup. When you compare that to the massive trauma, hemorrhage risk, and operative time of, an open abdominal laparotomy trying to navigate a frozen pelvis full of radiation adhesions.
It's night and day.
Yeah, the elegance of accessing and repairing the fistula entirely through the vaginal route is undeniable.
It specifically avoids the hostile abdominal environment, which minimizes surgical morbidity while maximizing the vascularization of the repair. And the longitudinal outcomes are what truly matter here.
Right. 18 months post-operation, her anatomy and fluid dynamics were entirely restored. The complex fluid shifts were completely arrested. The continuous vaginal leakage was gone.
And because the graft brought healthy blood flow, her bladder mucosa actually rebacterialized. her bladder compliance returned, restoring her functional capacity to a healthy 300 milliliters without the high-pressure spasms.
So the urodynamics normalized. The continuous shunting stopped. It completely reversed a structural failure that, historically, condemned patients to a lifetime of incontinence and isolation.
It proves that when we deeply understand the specific pathophysiology of the damage, in this case, the vascular obliteration, we can engineer targeted biomechanical solutions that bypass the body's acquired limitations.
It is a profound journey we've tracked today. We started by examining the silent, creeping devastation of radiation toxicity, how endarteritis obliterans slowly starves tissue over decades until the architecture simply dissolves.
Yeah.
We mapped the sheer physiological chaos that erupts when those walls fail, turning the body's own fluid dynamics into an agent of continuous physical and psychological breakdown. And finally, we explored how an ingenious, vascularized Trojan horse can smuggle life back into a dead zone, restoring structural integrity and giving a patient their life back.
It really is a masterclass in the resilience of human biology when paired with the relentless innovation of surgical science. We are no longer just focused on the blunt force trauma of eradicating a tumor. The field is evolving to master the incredibly delicate art of physiological reconstruction.
And grasping the mechanics of these late-stage effects is vital for you. Whether you're a clinician navigating these complex presentations, a survivor advocating for your own post-treatment quality of life, or simply someone fascinated by the extreme limits of human physiology, this shifts the paradigm.
Absolutely.
It forces us to look past the binary of surviving versus dying and focus intensely on the mechanics of living well after survival.
The definition of a cure has to encompass the functional reality of the decades that follow remission.
Which leaves us with a massive looming question. As our oncological interventions become increasingly precise, and as long-term cancer survival rates continue to climb globally, are we, as a medical infrastructure, truly prepared for a future where managing the multi-decade, highly complex physiological aftermath of our cures requires just as much innovation, funding, and clinical focus as the initial cure itself?
That's the real question.
Something for you to ponder. Until next time.